Dear colleagues, thank you for joining us for this fourth annual OncoAlert Colloquium, presented to you by OncoAlert and our esteemed partners at the American Society for Radiation Oncology, the European Society for Surgical Oncology, the European Society for Gynecological Oncology, MASC, the International Association of Supportive Care in Cancer, SIOG, the International Society of Geriatric Oncology, and the OncoAlert Global Consortium, which is made up of 12 medical oncology societies from low and middle income countries. The OncoAlert Consortium convenes to address critical issues impacting low and middle income countries, emphasizing the need for consensus on cancer treatment in resource-constrained settings. Today, we dedicate our discussions to strategies for maintaining cancer in the absence of essential drugs, spanning GU, GI, breast, lung, and gynecological malignancies. This marks the beginning of a global initiative aimed at enhancing support for healthcare professionals in low and middle income countries. Our esteemed speakers for today include Dr. Yuksel Urun from Turkey, Dr. Deniz Can Guven from Turkey, Dr. Arun Shahi from Nepal, Dr. Yaala Saadi Raof from Iraq, and Dr. Hein Tayzar Zoe from Myanmar. Without further ado, Dr. Yuksel will commence the presentations.
Hi all, this is Yuksel Urun. I am Professor of Medicine at Ankara University School of Medicine at Department of Medical Oncology. And thank you for OncoAlert for this organization and the opportunity. Today, my title will be How I Treat Genitourinary Cancers with Limited Resource, especially in Turkey. This is my disclosure. Actually, this is the key objectives of my presentation. Of course, we all know there is unique challenges in treating cancer with limited resource, and we all need to strategies and approaches that have been successfully implemented in this context. And I will try to give some practical tips and recommendation for healthcare professional in working resource-constrained settings. Actually, the practice of oncology in resource-limited regions requires adaptability, ingenuity, and deep understanding of the local context to provide the best possible care under the challenge circumstances. It brings us several problems, several barriers regarding some ethical issue, because as a physician, we always want to give best treatment available to our patients, especially patients with cancer. This is from the Colloquium 2020. Actually, our population is around 85 million, and each year we faced with more than 200,000 new cases of cancer, and half of them unfortunately died because of the cancer. Unfortunately, the most common cancer in Turkey still is lung cancer, followed by breast cancer, and of course, lung cancer is because of the smoking habit. And colorectal and prostate, of course, thyroid is most common cancer. But when we come to the males, for males, the prostate cancer is second and bladder is third most common cancer. In the first 10 cancers, we see prostate, bladder, and kidney cancer, and it's around 40,000 new cases of genitourinary cancer in our country. This is case by case, at least 20,000 prostate cancer, more than 10,000 bladder cancer, and half of this is around 5,000 kidney and 1,500 testicular cancer we see each year in Turkey. And prostate, bladder, and kidney and testicular is like a rank for commonest. And the prostate is most common cancer in the male, followed by bladder cancer. Also, bladder cancer is one of the most common cancer in our region, and this is also mostly because of the smoking habit. And when we come to for both sexes, age standard incidence and the mortality, prostate, lung, and bladder is still responsible for significant amount of cancer-related death. Okay, let's come to how we treat genitourinary cancer. Especially for our population, is more than 90% of our patients are covered by general health insurance, which is governmental insurance. Of course, we have some financial constraint, especially for new treatment option like a new IO, some TKI, some ADC, and at part of diagnostically also some NGS test is not widely available. When we come to the physician, especially we have very well-trained oncologists, urologists, and other healthcare professionals. There is no limit or barrier in this issue. Of course, some infrastructure limitation, but our radiotherapy is very modern. We have all type of the chemotherapy drugs and all surgical facilities are available. Compared with other the region, of course, there is some cultural barriers, but actually it's not very common now in Turkey. Still, there is some stigma associated with cancer and reluctance to seek medical attention, but it's not common. And the good news, also we have several clinical trials option, especially at our center and other referral center. There is a large amount of the clinical trial, and both patient and physician are very excited to be part of the clinical trials. Of course, clinical trials bring more opportunity to us and our patients to be able to reach new effective treatment earlier. Okay, now I will start with prostate cancer and go one by one. For prostate cancer, actually, when we look at the diagnostic tools, of course, PCA is available and accessible for all our patients. MRI also is very common in every city. We have MRI. Maybe we have more than we needed MRI. Also, most of the MRI is 1.5 Tesla, but also we have 3 Tesla MRI. It's all available and accessible. Bone scan, PSMA PET is very common in Turkey and we use widely. And when we come to the genetic disease, because we know some of the prostate cancer is genetically inherited, both we need to look at germline test, both somatic test, not only for the hereditary or family purpose, also it's like a now target for treatments, and we have a new treatment options for those patients. And BRCA1 available, accessible. Of course, it's not for all centers, but especially for referral center, both in governmental hospital and private practice is it available. HRD is actually limited. We don't have regular HRD test, but it is possible to send abroad for this test. Okay, now there is large amount of the treatment tools for prostate cancer. Of course, surgery is available. We have very good surgeon. Also, robotic surgery is available, but of course, access is limited, and in some center, patient need to co-pay. Radiation available and accessible. We have very nice radiotherapy infrastructure, IMRT, also in some center, even MR-Linac is available. When we come to the hormonal treatment, ADT as an agonist, LH-RH agonist, is all available and accessible for our patient. But unfortunately, antagonist is not available, but it's limited access. You know, patient need to pay for copay. All chemotherapy, docetaxel, cabazitaxel is available. We use without any restriction in our patients. And also, in new hormonal agents such as abiraterone and enzalutamide is available, accessible, and reimbursed in all part in patient with metastatic hormone-sensitive disease, metastatic castration-resistant disease, and also for enzalutamide in non-metastatic castration-resistant disease. Unfortunately, abiraterone is not yet reimbursed for patients with high-risk combination with radiotherapy. And also, apalutamide is available, but still not reimbursed. And darolutamide is not available, and there is no access to darolutamide at this point. But in next 1 or 2 years, we hope also we will be able to have access to darolutamide. PARP inhibitors, 3 of them, olaparib, niraparib, and talazoparib is all available. But there is not reimbursed yet, so that's why we have limited access. Patients have to pay their own. But when we come to the lutetium, it is available more than 10 years now, and we use very widely. There is no restriction in lutetium. But the best part in our country, we use lutetium after 1 or 2 line of treatment, especially after the docetaxel, a new hormonal agent, mostly there is competition between lutetium and cabazitaxel for 3rd line of the treatments. And of course, patient selection is the main criteria. And we use lutetium without any restriction. Radium-223 is not available, but in our center we have a radium part of the clinical trial, and we have several patients on this radium. And all bone-modifying agents like zoledronic acid and denosumab available and accessible, and of course reimbursed. Let's give one example from one of my recent patients. He is a 77-year-old gentleman with hypertension, diabetes, and COPD. At the admitting, his echo performance status is 2, with high PSA, high creatinine, and the biopsy shows Gleason 4+4 prostate adenocarcinoma. And in bone scan, we see widespread bone metastasis. So we can classify this patient de novo metastatic, high risk, high volume disease, especially now according to guideline. For patient with de novo metastatic, high risk, high volume disease, triplet treatment is recommended. But in this patient with several comorbidity and 77-year-old with low ECOG performance status, I believe doublet will be more appropriate for these patients, for this gentleman. And this is the all available treatment in our country. And for this patient, we can go with both ADT, abiraterone, prednisolone, or ADT plus enzalutamide, which is now available hormonal treatment. And at this stage, I don't think triplet treatment will be a good option for this gentleman. Okay, let's proceed with urothelial carcinoma. Unfortunately, it is very common in Turkey and 4th common cancer, especially in male, and again, because of smoking. And when we look to diagnostic tools, of course, cystoscopy tool is all available, both in hospital-based and private-based. It is very accessible, and also MRI, CT scan for staging purpose is available, and it is without any copay for all patients. And FGFR test, of course, we know after recently FDA approved FGFR inhibitor for the treatment of patients with specific alteration in FGFR2 and 3 for patients with advanced urothelial carcinoma. Of course, we have FGFR test, but there is limited access, and it's not available in all centers. Okay, and this is the treatment option, what we have according to stage. Of course, surgery is available, radiation is available, and any type of the chemotherapy, gemcitabine, taxane, like a docetaxel, paclitaxel is available. And also vinflunin, and also we can use dose-dense MVAC in neoadjuvant setting and other setting. And one of the real issue for us, actually still, we use in limited amount of the patient neoadjuvant chemotherapy for especially muscle-invasive bladder cancer. It's still less than 25%, but unfortunately, this is very common even in high developed center and referral center. So we still have to do more in this issue. And of course, immunotherapy now is one of the important part of the treatment in patients with bladder cancer, and avelumab approved as a maintenance treatment for patients who, after the platinum-based treatment, there is no progression. It means if you have a complete response, partial response, or stable disease, you can continue with avelumab. It is available, but still not reimbursed. Also, for patients who go under the surgery, adjuvant nivolumab, it's one of the available options, but not reimbursed yet. Also, pembrolizumab, which shows overall survival benefit after the progression with platinum-based treatment, is available in our country. We use in several patients, but there is no official reimbursement yet, so patients have to pay themselves. And erdafitinib, enfortumab, sacituzumab govitecan, and also EV-pembro combination, all is available, but none of them is still reimbursed by the government, and all that's why we have a limited access. It's not for all patients, unfortunately. And kidney cancer, kidney also is not commonest like prostate and bladder, but it is still, especially in male, it is one of the common cancer. And of course, all diagnostic tools, surgery, radiation is available for kidney cancer, fortunately. And adjuvant pembrolizumab for patients with high-risk disease after surgery is available, but unfortunately not reimbursed yet. And tyrosine kinase, sunitinib, pazopanib, cabozantinib, all is available. Cabozantinib only approved for patients with intermediate and or poor risk according to IMDC criteria. Sunitinib, pazopanib available for all patients, regardless of type of the disease, for both patients with clear and non-clear cell carcinoma, also cabozantinib, but for intermediate and poor risk disease. Everolimus is totally accessible and available. Nivolumab, we can without any restriction for patients with clear cell carcinoma after the progression on TKI, like a sunitinib, pazopanib, or cabozantinib, and you can use in second and third line. Adjuvant pembrolizumab, adjuvant nivolumab is not accessible now, as I said before. And now the combination, also pembro-axi, nivo-ipi, nivo-cabo, is approved combination, but still not reimbursed by the government. But we can use with limited access if patient have like a private insurance or able to pay from their own pocket, we can use. But there is at least maybe 10% of our patient has private practice. Also, we can use this combination for those patients. But pembrolizumab combination, it's even available, but not we have limited access. But the good news for RCC treatment, both for adjuvant and metastatic disease, we have several clinical trials options, and we have some referral also from our center. Wherever possible, we try to have access to clinical trials. And this is the algorithm in 2024 for kidney cancer. For first line, as I said before, cabozantinib, pazopanib, and sunitinib is accessible and approved combination. Nivo, ipi, nivo, cabo, pembro, axi is all approved, but not reimbursed yet, and also clinical trial available for first line. And second, third, and fourth line, we use agent which we have not used before in the disease, and after the progression, we have axitinib, cabozantinib, everolimus, and nivolumab in other line. Okay, testicular cancer, actually we have all type of treatment for testicular cancer. There is no restriction. We have very good and very experienced surgeon for testicular cancer, both for orchiectomy, for retroperitoneal lymph node dissection, also for residual surgery. Patient who have still residual disease after the chemotherapy, we can have a surgery for those patients. We have a very good talented and very experienced surgeon. Even we use radiotherapy less in testicular cancer. Of course, we have a radiation and all type of chemotherapy. The first and gold standard still BEP, and of course other type TIP, VIP, Gempox we have. And also we can do high dose chemotherapy with autologous stem cell transplantation. It is available, but in referral center, but it is accessible for all patients. Of course, since those patients are young patients and maybe they need sperm cryopreservation. At our center, of course, we have, and in many centers we have sperm cryopreservation, and we try to do before any treatment, even before the surgery. So actually, there is still strategies to enhance GU oncology care in resource-limited settings, and there is, but what we need, especially we need collaboration, we need training, we need capacity building, we need developing. Of course, we need local adapted clinical guidelines. And I think the important part, we need to promote public awareness and early detection, because this is one of the most effective treatment strategy for every part, but especially for region with limited resources. And with this, I want to thank, and again, thank you OncoAlert for the opportunity to present our data. And thank you very much for listening us. Thank you.
First of all, I would like to thank OncoAlert Network for giving me an opportunity to represent on this great platform. On the seventh day of OncoAlert Colloquium, as a part of OncoAlert Consortium sessions, today I will talk about how we treat GI cancers when we don't have access to drugs. My name is Deniz Can Guven. I'm a medical oncologist from Turkey, and I will try to summarize our adaptive strategies in regions where we have limited access to the recently developed therapies. I have no conflict of interests. So my presentation plan will be as follows. Before pass on to the data, first I will talk about why these OncoAlert consortium sessions are needed. As we all know, the cancer burden is still high in low-income countries, although the communicable diseases are more important than the developed part of the world. However, even in the low-income countries, we have around 500,000 people are diagnosed every year with cancer, and also the number of deaths due to cancer are very high compared to the developed regions. A, a significantly higher cancer burden is present in low middle income countries. We have over 3 million people are diagnosed in cancer in low middle income countries, and also almost 2 million people yearly dies due to cancer. In the upper middle income countries, including my country, Turkey, almost 8 million people yearly are diagnosed with cancer, and over 4 million people are died due to cancer yearly. And the fatality rates in the upper middle income countries are still high compared to the high income countries in the upper middle income countries. Other than this significant cancer burden, according to the AICR Cancer Progress Report in 2023, the estimated new cancer cases in the next 20 years will predominantly be from low and medium and low income countries, and the increase in the new cancer cases will be over 60% in these countries. So, in summary, over half of the newly diagnosed patients with cancer are from low income countries, and high mortality rates are observed in these regions. And the global organizations expect over 60% increase in the next 20 years in cancer burden in these regions. And we have significant need for improvements in cancer care in these regions. However, a bright spot is small steps could be big for low middle income countries like my country. So before we dive into the data, I would like to have your attention to another topic, which is what is the current status of drug access in low middle income countries in GI cancer and also in general in oncology. I would like to have your attention to two great studies. One published in Lancet Oncology 2 years ago. In this study, conducted over 80 countries, you can see that even the chemotherapeutics are limited in access in low-income countries, and also in these countries, the risk of catastrophic expenditures, which was defined as spending over 40% of the total consumption, total spending on food spending, was higher in low middle income countries. In other words, if the drug access in low middle income countries was similar with similar prices in low middle income countries, it could disrupt all parts of daily living, including the food access. We have another great data presented in the recent ESMO, and in this study, over 200 experts from 110 countries was surveyed, and the survey population was presented over 100 countries. Here you can see in the low and lower middle income countries, access to most conventional chemotherapeutics are paid full cost by the patients themselves. In most of the low-income countries, there were no institutional level, country level reimbursement for even for chemotherapeutics, and also in some parts of the world, access to simple chemotherapeutics like irinotecan or capecitabine was also very limited. Regarding to targeted therapy and immunotherapeutics, unfortunately, in lower middle income countries, access to most immune checkpoint inhibitors was almost impossible, and also access to immune checkpoint inhibitors, anti-EGFR drugs, and even the trastuzumab and biosimilars was very limited. And in several countries, the access to these medicines was via out-of-pocket full cost payments. Unfortunately, even in the upper middle income countries, for example, in several countries like Azerbaijan and also Libya, Malaysia, the patients were required to pay full costs for immune checkpoint inhibitors. And for example, in Turkey, we were at significantly better shapes, but in most lower middle income countries and upper middle income countries, even the older drugs like trastuzumab and anti-EGFR inhibitors had very limited access. So, in summary, although the developed parts of the world are currently living in an area of precision medicine and great advances in the cancer care, the situation is more like the panel in the right-hand side, which was a post I saw on Twitter, and actually this post was greatly summarized the difference in the low middle income countries. So after this introduction, I will talk about our alternative approach to current standards of care in the upper GI, and I selected 4 scenarios for that. First, I will talk about chemo-IO combinations in the first line treatments of gastric, gastroesophageal, and esophageal cancer. And second, I will talk about our alternative approaches to IO-based combinations in advanced HCC. After that, I will talk about possible alternatives to targeted treatments in biliary tract cancer. And after that, I will talk about an alternative approach to first-line and maintenance strategies in pancreatic cancer. As we all know, the chemo-IO combinations became the standard of care in the first-line treatment of gastric, gastroesophageal, and esophageal carcinoma after the results of Checkmate 649 and also Keynote 519 and also Keynote 859. And in the studies, addition of immune checkpoint inhibitors to chemotherapy was associated with significant survival benefits, and survival benefits was evident, was more pronounced in biomarker selected patients, although several studies suggested a benefit across all patients. And these studies entered the guidelines, and chemo-IO combinations became standard of care for most patients with gastric gastroesophageal carcinoma and also the esophageal carcinoma. However, in lack of IO reimbursement, actually we have very limited options. We maybe try to optimize the first-line treatment by changing the chemotherapy backbone. We have a GasFox trial presented in ESMO 2023, and also we have DOC gastric cancer trial presented in ASCO GI 2024. These trials basically evaluated the addition of docetaxel to the oxaliplatin and fluorouracil based regimens. In the GasFox trial, the patient with gastric or gastroesophageal junction carcinoma were randomized to FOLFOX and FLOT or TFOX arms. The randomization was 1-to-1, and the primary endpoint was overall survival. Regarding the efficacy, the triplet regimen was associated with a 9% increase in the response rates, and also the triplets was associated with 1.5 months of PFS benefits, and also the triplets was associated with an overall survival benefit. The median OS was 15 months with triplet and 12.6 months with the doublets. And the benefit was especially pronounced with patients with a better eco performance status, and the quality of life was improved in the triplet arm. So this was very promising, but however, in the very recent presentation from ASCO GI 2024 from the India Tata Memorial, Dr. Ramaswamy presented two data from the DOC gastric cancer trial, which was an investigator-initiated multi-center phase 3 trial. This trial compared K-FOX or FOLFOX for a maximum of 6 months with oxaliplatin fluorouracil docetaxel and with docetaxel maintenance after the 4 months of treatment, and the primary endpoint was overall survival. Unfortunately, the overall survival was similar with two arms, and also the progression-free survival was similar across two arms. So therefore, we still do not have enough data regarding to the chemotherapy intensification in patients with metastatic gastric and gastroesophageal carcinoma. Although in patients with a very good performance status and limited tumor burden, this could be used in my humble opinion. So regarding HCC, the immune checkpoint inhibitor-based combinations became the standard of care in advanced HCC. And here you can see the famous Embrace study, and you can see the significant PFS and OS benefits with atezolizumab plus bevacizumab compared to sorafenib. And here in the Himalaya study, the combination of durvalumab trevalumab was associated with a 2.6 months overall survival benefit compared to sorafenib. And this combination became standard of care options in the first line settings, and the guidelines only recommended TKI monotherapies if these regimens are not feasible. However, in the lack of IO reimbursement, we mostly use tyrosine kinase inhibitors sequentially, and in my country we use sorafenib, and after that we use regorafenib. And in several Asian countries, the chemotherapy is still in use, and there was a old Asian study. Each study tested FOLFOX in the first line treatment of advanced HCC. Here you can see the timeline of drug approvals in HCC, and from these approvals, our patients are benefiting from the results of SHARP trial comparing sorafenib with placebo in the first line setting, and sorafenib was associated with around 3 months survival benefit in the first line, and also regorafenib was compared with placebo in the second line, and this was also associated with around 3 months survival benefits. But after that, several approvals with immune checkpoint inhibitors in the second line as monotherapy, and also first line use of lenvatinib, and also second line use of cabozantinib, and the first line IO-based combinations are not available, unfortunately, in our country. Regarding the chemotherapy, we have data from one study, each study, which was from Asia, and this study compared oxaliplatin plus fluorouracil 5-FU with doxorubicin, and here the FOLFOX was preferable to doxorubicin and was associated with a modest overall survival benefits, and also response rates were better, although in both arms response rates both with FOLFOX and also doxorubicin was lower than 10%. So in biliary tract cancer, currently the targeted treatments are very important. Here, I would like to have your attention on this figure. It was taken from a very recent paper by the Tam et al. published around 2 years ago, and this demonstrated the drug availability on Canada in biliary tract cancer. Here you can see FGFR inhibitors, interact inhibitors are reimbursed and available, and also most of the drugs are available, although some are not reimbursed in Canada. And here you can see currently the guidelines recommending gemcitabine plus IO either in durvalumab or pembrolizumab as the first line, and targeted therapies in the second line settings. Here you can see in the first line topaz-1 study. This study compared gemcitabine with the gemcitabine plus durvalumab and demonstrated a modest survival benefit with the triple combinations. And regarding the precision medicine approaches in the second or later lines, in patients with FGFR2 alterations, the use of pemigatinib was associated with over 30% response rates and around 20 months overall survival in the FIGHT 202 study. And in the CLARI-IDHI study, the patients with biliary tract cancers and IDH mutations had significant progression-free and overall survival benefits with the use of ivosidenib and IDH1 inhibitor compared to placebo, and the overall survival benefits after the adjustment for crossover was around 5 months, although the drug was very costly and currently very costly in our country. So in biliary tract cancer, actually, our options are very limited in order to improve outcomes, and the most of targeted therapies in biliary tract cancer are available or not reimbursed in low middle income countries. So we try to give chemotherapy in second line also, and we have data from the ABC-06 study. This study was presented in ASCO 2019 by Angela Lamarca and compared FOLFOX in the second line with active symptom control. Here you can see the baseline characteristics were similar across arms, and the study was met its primary endpoint with a hazard ratio of 0.69, and also the progression-free survival with the FOLFOX in the second line was 4 months, which was also promising. So other than using chemotherapy in the first and second lines and giving 2 lines of systemic treatments is unfortunately the only thing that we are trying to do in our clinic, other than the clinical trials. Although clinical trials is very important for us in order to reach several new drugs. So regarding pancreatic cancer, we have very recent data from the Napoli 3 trial. In this trial, 5FU, recovery, and oxaliplatin was combined with liposomal irinotecan in one arm, and this was compared with gemcitabine and nab-paclitaxel in the other arm. And this triple combination was associated with 2 months overall survival benefits in phase 3 Napoli 3 trial. And regarding the maintenance in patients with BRCA1 and 2 mutations, the olaparib had a progression-free survival benefits in use as maintenance, and also in patients with pancreatic cancer and pathogenic germline or somatic BRCA1 or 2 or PALB2 variants. In the single-arm phase 2 study, the use of olaparib in maintenance was associated with around 2 years of overall survival. And here you can see the nalirifox, the Napoli 3 regimen, became one of the standard options in the first line, and PARP inhibitor-based maintenance became the standard maintenance for patients with mutation in the guidelines. However, due to unavailability of these therapies, I think it's very important to use triplet regimens as much as possible in the first line. And from the Prodigy 4 study, I'm very sorry. Prodigy 4 study, we use FOLFIRINOX mostly, and also there was a very promising study presented very recently. It was a sequence study suggesting changing chemo backbones in patients without progression. And also we have data regarding maintenance 5FU from the Prodigy 35 study. I would like to discuss the sequence study in this phase 2 study. The patients with advanced metastatic pancreatic cancer were randomized to nab-paclitaxel plus gemcitabine and nab-paclitaxel gemcitabine and FOLFOX in sequence without progression. Here you can see with the sequencing of therapies, the response rates were almost doubled, and also progression-free survival was prolonged over 2 months with sequential use of gemcis and FOLFOX. And most importantly, the overall survival was prolonged with combination. Although it was a small phase 2 study, the results were promising. And actually, this sequencing did not disrupt the optimal chemotherapy use and dosing. Regarding maintenance, we have data from the Prodigy 35 study, which was presented in ASCO 2018. In this study, I don't want to talk about the RC because it was negative, but the use of FOLFIRINOX continuously and the 5FU maintenance after 8 cycles of FOLFOX were compared. Here you can see the 6-month progression-free survival rates was similar in patients who were treated after the stopping of oxaliplatin, and also progression-free survival was numerically very similar, and the overall survival was similar with the early stopping of oxaliplatin. So therefore, in our daily practice, we try to use triplet regimens and try to stop oxaliplatin after 4 months, and also using gemcitabine and paclitaxel and FOLFOX interchangeably is another option in patients who are not appropriate for triple regimens. So regarding global GI, I would like to have your attention to 3 scenarios. These are new standards in third-line treatment of advanced CRC, and also the use of IO in the neoadjuvant settings in the MMR deficient rectal cancer, and also the use of IO in the MMR deficient colorectal cancer. The third-line treatment of colorectal cancer area became very crowded with the advent of targeted therapies, and we have licenses for several targeted therapies, and also we have several TKI and anti-VEGF combinations. Here, I would like to discuss several of them. In the very recent Sunlight trial, which was presented in ASCO GI 2023, the TAS-102 plus bevacizumab was compared with TAS-102, and this combination use of TAS-102 and bevacizumab was associated with over 3-month survival benefits in patients treated with at least 2 prior regimens, and this combination became one of the preferred regimens in the third line. And also regarding precision oncology approaches in patients with HER2-positive metastatic colorectal cancer and at least 2 lines of treatment, the use of tucatinib plus trastuzumab was associated with an overall response rate over 35%, and also and the median PFS was 8 months, and survival was over 2 years. And these combinations was also became one of the preferred regimens for HER2-positive metastatic colorectal cancer. And in the very recent CodeBreak 300 phase 3 study, and this study was presented in the presidential session in the ESMO 2023, in patients with KRAS G12C mutated colorectal cancer and who had at least 1 line of treatment, the combined use of sotorasib plus panitumumab was associated with a significant progression-free survival benefits, and also the combination of either sotorasib plus panitumumab was associated with a response rate of 26%, which was kind of unpresidential for this line with conventional tyrosine kinase inhibitors. And also in the FRESCO trial, the patients who were previously treated with oxaliplatin, irinotecan, 5FU, and one of TAS-102 or regorafenib was treated with fruquintinib or placebo, and in the largely fourth-line setting, the inactive drug fruquintinib was associated with an overall survival benefit. So therefore, currently we have at least 4 lines of treatments in the treatment of metastatic colorectal cancer. However, in the lack of reimbursements, we try to use re-challenge chemotherapy, and also we try to use anti-EGFR re-challenge for the RAS wild type patients. So the re-challenge chemotherapy was actually mostly compared with regorafenib previously in the literature, but actually these studies were real world studies, and we do not have any clinical trials. I would like to have your attention to two studies from Turkey, and in both of these studies, overall survival benefits was reported with the use of chemotherapy compared to the thyroid kinase inhibitor comparator, although it could not be excluded that patients treated with chemotherapy in the later lines could have more robust performance status, although similar trend in several studies was hypothesis generating and could be promising. Regarding the anti-EGFR challenge, we have small phase 2 studies, one with cetuximab in the later lines. Here you can see in the ctDNA RAS wild type patients, the use of anti-EGFR challenge was associated with 4 months of PFS and over a year of overall survival. Similarly, in the Kronos, patients treated with anti-EGFR in the first line and had another line of treatments. The anti-EGFR challenge in the third line setting was associated with a response rate of 30%, which was very promising. So, considering the relative low cost of anti-EGFR agent, we try to use chemotherapy re-challenge for advanced lines, and also we try to use anti-EGFR re-challenge in the later lines due to unavailability of PAS102 and also fruquintinib in my country. So regarding the use of IO in the neoadjuvant settings for localized rectal cancer, most of us were accustomed from came familiar from these concepts from the Chalabi plot in ESMO 2022, and in the niche 2 study, the patients with localized rectal cancer was treated with one cycle of nivo plus EP and another cycle of nivo, and these patients had major pathologic response in the 95% of the patients, and also 2/3 of the patients had complete clinical response, complete pathological response. And also, we also have another similar study published in the New England Journal of Medicine over a year ago, and here the use of immune checkpoint inhibitors in neoadjuvant settings was associated with a clinical complete response in all of the response available 14 patients. So after that, the NCCN guidelines incorporated the neoadjuvant use and also the definitive use, even without radiotherapy, use of immunotherapy in neoadjuvant settings for 6 months, and in patients who are not without an access to immune checkpoint inhibitors, the guidelines were mostly recommended total neoadjuvant therapy, and in my country, actually, I tried to use total neoadjuvant therapy in a more widespread manner in the MOI deficient localized rectal cancer, and we have recent data from 2 studies, and in the Polish 22 study, the patients with locally advanced rectal cancer were randomized chemoradiotherapy and surgery and adjuvant chemotherapy, and FOLFIRINOX chemoradiotherapy, surgery, and adjuvant chemotherapy arms. And here you can see the efficacy results with the introduction of FOLFIRINOX in neoadjuvant settings as a part of total neoadjuvant approach. The use of early chemotherapy was associated with a 7% absolute disease-free survival, and also the metastasis-free survival benefits, and also the complete response rates were doubled with the early introduction of chemotherapy. And here, in the Rapido trial, which was a true neoadjuvant trial, the use of short course radiotherapy and after 18 months of oxaliplatin and 5-FU was compared with no-course chemoradiotherapy and adjuvant chemotherapy. This study was also included patients with locally advanced disease. And here you can see the disease-related treatment failure was improved over 7%, and also the distant metastasis was decreased 7%, and the hazard ratios were over 0.7 for both outcomes. So therefore, I think that's for the locally advanced MMRD localized rectal cancer, we try to use total neoadjuvant approaches as much as possible. Regarding the advanced MMRD colorectal cancer, we have data from the Keynote 177 study. Here in this study, the conventional chemotherapy was compared with pembrolizumab in the first-line setting. Here you can see the progression-free survival was doubled, and the median duration of response was significantly longer with immunotherapy. And the study demonstrated numerical survival benefits favoring the use of immunotherapy as early as possible. Very recently, in the ASCO GI 2024, we heard the results of Checkmate's 8HV study. In this study, the combination of Nemo plus EP was compared with investigator choice chemotherapy. Here you can see the earlier use of combination immunotherapy was associated with a significant progression-free survival benefit with an exciting hazard ratio of 0.21. So therefore, the use of IO is irreplaceable in this setting. So I think other than the introduction of generics or more cost-friendly IO agents, I think maybe we could in the later we could use low-dose IO for low-middle-income countries. Although there were several data from the real world, we have no studies in colorectal cancer suggesting that the use of low-dose IO is acceptable. But however, several studies in other tumors suggesting that the low-dose IO could be as effective as possible for the indications that we use immune checkpoint inhibitors. Here you can see a real-world data in non-small cell lung cancer. The use of pembrolizumab in 200 milligrams for 3 weeks or 100 milligrams for 3 weeks was associated with similar progression-free and overall survivals. And also in a very important trial, the only clinical trial the only randomized trial, prospective trial in this issue was published in JCO over 2 years ago. And in this study by Patil et al., the addition of immunotherapy, duometronomic chemotherapy was associated with an overall survival benefits. And in the study, the researchers used a very low dose of immune checkpoint inhibitors, and the used immune checkpoint inhibitors dose was 20 milligrams nivolumab per 3 weeks, and actually it corresponded around 5% of the regular dose, and they observed a similar overall survival improvement to standard dose IO from the similar studies in head and neck cancer, and they observed no increase in high-grade adverse events. And actually, if this kind of prospective randomized trials will expand, maybe our patients could have a greater access to IO in low-middle-income countries. So in summary, for gastric cancer, IO plus chemotherapy is the new standard of care, and the triplet backbones are not optimal alternatives in the settings. And for liver cancer, the IO-based combos are the new standard of care. And unfortunately, the previously used standard of cares, tyrosine kinase inhibitors, are still expensive for most countries. So therefore, the access to IO should be expanded as early as possible. Regarding the biliary tract cancer, actually, we do not have any real alternatives to targeted therapies. And for for the MRD colorectal cancer, we do not have no real alternatives for IO. So, in summary, immune checkpoint inhibitors are now a part of standard of care in most GI cancers, and they are actually especially irreplaceable in the MMRD or MSI high tumors. Considering the high cost of IO, I think that low dose IO trials should be expanded, and the need for budget friendly targeted therapies are needed for all tumors, but especially needed for biliary tract cancers in GI tumors. But as I said at the beginning, I think that small steps could be big for low middle income countries, including countries for my country, Turkey. With that, I'd like to conclude, and thanks again to our national organization, Turkish Society of Medical Oncology, and the OncoAlert Network for having me here. And thank you very much for your attention.
Namaste. Greetings from Nepal. I am Dr. Arun Shahi, Assistant Professor of Medical Oncology at Patan Academy of Health Sciences, Nepal. Today, I'll be talking about how I treat cancer when I don't have the drugs. For this, I would like to thank Dr. Gil Morgan for this opportunity and whole the OncoAlert team. I'm very grateful to them for this opportunity, and it's very pleasant moment for me that I'm sharing our experiences to the entire oncology world. So agenda of today's presentation is how we manage hormone positive breast cancer, how we manage HER2/neu positive breast cancer, and also the triple negative breast cancer. So this is the hospital where I work. It is a deemed university. We have undergraduate and postgraduate programs running in this hospital, and more than that, we also have the School of Nursing and School of Public Health. To talk about Nepal, Nepal is a landlocked country. Total land surface area is 147,181 square kilometer, and the life expectancy of Nepalese people is 72.4 years. If we look for the male, it is 71.66 years, and for the female, 73.1.7 years. We also have 4 or 5 comprehensive cancer treatment hospital in Nepal, but most of the cancer center here in Nepal are without the radiation oncology facilities, or we don't have the radiation machine. But those hospital, or even the hospital where I work, we don't have the radiation machine, so we don't have the radiation facility. But beside radiation facility, we have all the facility of the prevention, screening, early detection, and treatment, especially surgery and chemotherapy. In Nepal, government have some subsidy scheme for those patients who are diagnosed with the breast cancer or any cancer. Like, for example, if someone is diagnosed with the breast cancer, they will get 100,000 Nepalese rupees for the treatment. And with the provincial government also provide some help. Like, for example, some provincial government provide 50,000 Nepalese rupees up to 300,000 Nepalese rupees for the cancer care. And they also provide monthly 5,000 allowance for their regular cost backup. But these medications are given to only those treatment which are under the WHO, NCCN, ESCO, ESMO, or our local protocol. Beside the government subsidy, we also have the collaboration with the Max Foundation, which is American Seattle-based non-governmental organization. There we have some free medication. They provide free medication for the chronic myeloid leukemia, that is imatinib, ponatinib, CA lung, adenocarcinoma, ALK positive, ROS1 positive lung cancer medicine, crizotinib, lorlatinib. For the medicine for the GIST, that is gastrointestinal stromal tumor, that is imatinib, sunitinib. For the kidney cancer, that is sunitinib, exitinib, temsirolimus. And recently we have added for the breast cancer, hormone positive, stage 4 metastatic breast cancer, they are providing the first line ribociclib and letrozole free. So if you see the number, we have almost 2,000 people all over Nepal getting this medicine in free of cost. So we are very thankful to this foundation. And beside this treatment activities, we also conduct academic activity in our oncology department. We have total 15 daycare oncology beds, and other are all inpatient beds. To talk about the incidence of cancer in Nepal, the lung cancer is the most frequently diagnosed cancer in Nepal, followed by breast cancer, cervical cancer, stomach cancer, colorectal cancer, and gallbladder cancer. If we see the incident rate only in females, breast cancer is the topmost cancer in Nepal, followed by cervical cancer, lung cancer, gallbladder cancer, and so on. And in case of mortality, carcinoma of cervix is the number one, followed by breast cancer, lung cancer, gallbladder cancer. About that, how we treat the cancer patient here in Nepal, it is same like the rest of the world. During a few years ago, that there were the traditional approach of this breast cancer treatment. For example, if the patients had an operable lump or lesion, they used to go with the mastectomy first, and then followed by the adjuvant therapy. And those breast cancer lump which are not operable, in that case, we used to try with the neoadjuvant therapy, followed by breast conserving surgery or total modified radical mastectomy. But now we do not go or treat the breast cancer patient in that way, but we instead we look for the biological subtypes, and according to the subtypes, our treatment follows. For example, if there is HER2 new positive or triple negative, for them we usually prefer the neoadjuvant. And for the ERPR positive and this HER2 negative breast cancer patient, if they are operable, first we go with the surgery, then followed by the adjuvant chemotherapy or surgery, radiotherapy. So how do we select and sequence therapy for the HR positive, HER2 negative breast cancer? Yes, for that, if it is early breast cancer, we look for the gene expression assay to decide whether they need adjuvant systemic therapy or not, or only hormonal therapy. For that, we do the oncotype diagnosis or mama print. But these tests are not available in Nepal, so for that we have to send it in the India. But if then this is also expensive. If the patient can afford, we send it to the nearby country, India, or Thailand or Singapore. But if they cannot afford, we usually start with the adjuvant chemotherapy, followed by hormonal therapy. And we are also familiar with the Telerex, and we also treat according to this outcome. And we are also familiar with the responder to decide whether they need adjuvant endocrine therapy or not. And then sometimes we also do the additional genetic profiling techniques, for example, germline BRCA1, 2, and also we now all the pathologists with this IHC immunohistochemistry reports on ERPR positive, they also provide the Ki67 reports. Sometimes we know that there are so many studies, phase 3 trials, they show that there might be some role of CDK4/6 inhibitor in early stage HR positive, which has the more chances of the recurrence. In my center, ribociclib and letrozole is free of cost. So if they are on, they follow the NATALY trial, we include them in provide them this ribociclib and letrozole. What about the selection and sequencing of targeted therapy for HR positive, HER2 negative metastatic breast cancer? For this kind of patient, we follow the NCCN guidelines, and I'm saying it again that ribociclib and letrozole is freely available in my center. So for the earlier in the first line setting, if they have metastatic breast cancer, hormone positive, for them we provide that medicine. And if they progress on that medicine, we also do the additional test, for example, PIK3CA mutation, and also BRCA1, BRCA2. If they can afford, we usually advise them for these targeted agents. But if they cannot afford, in that case, we again go with the chemotherapy. So based on this Mona Lisa trial, for the Arun positive metastatic breast cancer, we also give this ribociclib and letrozole. So this is our sequencing in the first line. We usually give the CDK4/6 inhibitor with anastrozole or letrozole. And for the some few patients, we also, if the disease volume is more, in that case, we also provide the CDK4/6 inhibitor with fulvestrant injection. The beyond the first line treatment, we look for the alpelisib for PIK3CA mutation, PARP inhibitor, olaparib, and everolimus. And this is our treatment sequence for HR positive, HER2 negative metastatic breast cancer. How about HER2 positive breast cancer? Again, we follow the NCCN guidelines for this. And those patients who can afford the pertuzumab, for them, we can go with the TCHP regimen, docetaxel, carboplatin, trastuzumab, and pertuzumab. But those who cannot afford, for them, if they are early stage and disease volume is low, for them we give the paclitaxel and trastuzumab. Most of the patients, they receive docetaxel, carboplatin, and trastuzumab combination. But these medicines are even a little bit expensive. In that case, if the patient is very poor, for them we also use another regimen, AC followed by T plus T, and the trastuzumab we give for altogether for 1 year. And we are also familiar with this affinity trial, Catherine trial, extension net 5 years update, niratinib, use of niratinib. But again, I would say that we follow this NCCN guidelines and also the patient's economic status, whether they can afford or not. Based on this, we try to follow first line, second line, third line. But if they cannot afford, in that case, after the first line or second line, we again start giving the chemotherapy for them, this patient. These are all the phase 3 trials, and we are familiar with these studies. And we actually, when we are counseling the patient earlier, we try to tell about this benefit and harm, and what the overall survival rate and disease-free and progression-free survivals, all we discuss with the patients. So this is the approach to the therapy for the metastatic HER2 disease, if we have to personalize the treatment. And what about the triple negative breast cancer? We know that triple negative breast cancers accounts for 10% to 70% for all breast carcinoma all over the world, and which is also similar to the patient we see here in Nepal. In Nepal, hormone positive breast cancer is the most common. I would say 70 to 80% are hormone positive breast cancer, followed by 10 to 15% are ER positive, ER negative, PR negative, HER2 positive breast cancer, and then 5 to 10% are triple negative breast cancer among our Nepalese patient in Nepal. So again, for this, we follow the NCCN guidelines and we treat accordingly. But if there is any financial problems or difficulties, we again go only with the chemotherapy. But most of the triple negative breast cancer, we do the biomarker testing, that IHC and molecular in the first hand. If the PD-L1 expression is higher than 1%, you can say PD-L1 is more than 1%. In case of triple negative breast cancer, we do the neoadjuvant immuno plus chemo. And for the germline BRCA positive, after the finishing of the chemo immuno, we offer them the oral olaparib as well. But also it depends upon the financial condition. If the financial condition is poor and if they cannot afford, we usually give them a chemotherapy. We actually rotate the chemotherapy. We start with the AC followed by T regimen if they are physically fit. And but if they have any cardiac issue or cardiac problem, then we start with the other agents like taxanes or antimetabolites or other microtubule inhibitors, and even platinum agents. So sometimes some patient, after the initial chemotherapy, we also do the BRCA1, BRCA2 mutation, especially for those patients who have a rich family history or 2 or 3 siblings or family members are diagnosed with the breast cancer. In that case, we do the germline BRCA1 to BRCA2 mutation. So what do we decide to BRCA1, BRCA2 mutation? It's the same like if the patient has a less than 50 years of age, we diagnose the breast cancer, or less than 60 years, diagnosed with the breast cancer with TNBC subtypes. And if the patient have a bilateral breast cancer or history of ovarian cancer at any age, or any first or second degree relatives, if they have a this kind of history, we ask them for the germline BRCA1, BRCA2 mutation. And even sometimes if they have a high family history, we send them for the germline mutation. We know there is also relationship between MSI and MMR and relation with this what the use of immunotherapy. If there is a MSI high, then we also look for the or advise them to use the chemo and immuno. So to conclude, we know that we oncologists are aware about the latest update and guidelines, but due to financial constraint, we cannot follow the guidelines to all of our patients. For them, we have to compromise and give the chemotherapy. So I would say still in Nepal, chemotherapy is backbone for the most of the breast cancer patient after surgery and radiotherapy. Thank you very much for the opportunity.
Good morning, everybody. My name is Dr. Yaala Saadi Raof. I am from Iraq. I am a medical oncologist from Al-Amal National Cancer Center in Baghdad. My presentation today about treatment of lung cancer patients in low and middle income countries, Iraq an example. My presentation will include epidemiology, risk factor, challenges, future perspective, and conclusion. According to the epidemiology, the official number from the MOH, according to 2021, lung cancer is the second most cancer in Iraq, around 12% of all cancer patients, while in mortality, the lung cancer is the top 10 of cancer death, around 21 or 22% of all cancer death. According to the age between male and female, the most common age of lung cancer for male and female is 60 to 70 years, which lead to us that the age challenge is a big challenge because we need to aggressive treatment in old age patient. The histopathological type for both male and female are different. For male, we have the squamous cell carcinoma, while for female, we have adenocarcinoma, and this may be due to smoking effect. The risk factor for lung cancer in Iraq, mostly due to smoking. The only official survey in Iraq showed the survey, Global Youth Tobacco Survey, recently conducted in Iraq, showed that 20% of all population are smoker, and 11% of the youth are currently smoker. But it's true or not? I think, personally, this is the iceberg phenomenon. The smoking incidence may be higher than this number, and this lead to more incidence of lung cancer in the future. Our challenges. Our challenges like the same of all low and middle income countries, starting from screening program, tissue biopsy, infrastructure, patient preference, cost of diagnosis, cost of treatment, treatment access, supportive treatment, the ongoing update, the guidelines, and the MDTs. Starting from screening program. Until now, only one screening trial in Iraq and no applicable screening program for lung cancer due to many causes. One of the major causes is the cultural rejection of the screening, because all our patient or our population refuse the idea of being a cancer patient. So I will not go for screening. When I have symptom, I will go. If I don't have symptom, I will not go for screening. The tissue biopsy, as many other global health problems, tissue biopsy for lung cancer is limited for many reasons. That's why cytology is still valid in spite of our need about molecular test. Infrastructure, most of our hospitals contain CT machines and bronchoscopy sets. Our lab, histopathological basic lab available, immunohistochemistry available in most of the central hospitals, molecular test available in reference labs only. Patient preference. As I said, patient refuse screening, refuse most of biopsy types, including bronchoscope, CT-guided biopsy, ultrasound biopsy, and the main cause is myth, because the patient believes that the biopsy will make the cancer spread and make the patient worse. Patient afraid from dyspnea due to bronchoscope. Patient afraid from the pain of CT-guided biopsy. Patient afraid from pneumothorax due to CT-guided biopsy. And all these things make our patient reject the biopsy, reject the screening program, and later on, they present in advanced stage. Continue our challenges. Diagnosis cost. Biopsy available in the governmental hospital free of charge. Molecular test, the basic molecular test nowadays available free of charge. Before maybe 3 years, we don't have molecular test free of charge. The NGS not available free of charge. So if I want to send patient for NGS, it will cost the patient. The cost of the treatment, including chemotherapy, radiotherapy, targeted therapy, and immunotherapy, we'll discuss on. The chemotherapy available in free of charge in most of our hospital and cancer center. Targeted therapy nowadays, we have anti-EGFR, anti-ALK, free of charge also. But before 2 years, we have only anti-EGFR. Immunotherapy nowadays available for lung cancer, and we have 2 immunotherapy agents. Before 2 years, we don't have immunotherapy for lung cancer. So the patient, if he wants to take targeted therapy or immunotherapy at that time, which is not available, it will be a high cost for the patient. For radiotherapy, we have 10 out of 18 major cities contain radiotherapy machines. And in the future, the MOH plan to cover all Iraqi cities with radiotherapy machines. We don't have a waiting list. The technique variable, but most of the recent and advanced technique available, including IMRT and VMAT. Supportive treatment. In some centers, there is a limitation for access to narcotics, example, oral morphine. There is no formal hospice care because the patient refused to admit for a ward that he will die in. So the palliative care, in collaboration with internal medicine department, most of our hospital admit the cancer patient for palliative care as a team for internal physician and medical oncologist. The ongoing update, as you know, the lung has the highest ongoing update in the diagnosis and the treatment, and this leads to higher cost and difficult to cope with this cost. So we will be in need for advanced technique like NGS. We need a new therapeutic agent. We need experience for this new technique and a new agent, but this leads to higher cost. So we need to better planning for diagnosis and treatment facility, better planning for guidelines, our local and national guidelines. We need to collaborate between the teaching center, the association, and the global association for better training and CME. So in conclusion, we have as incidence, second most cancer incidence, around 12% of all registered cancer. The highest cancer death percentage, around 22%. The risk factor is the smoking is the leading cause. Social and cultural factors affect the diagnosis and the treatment. Tissue biopsy is still difficult in non-metastatic lung cancer. Molecular test still limited. Treatment, standard chemotherapy available, targeted immunotherapy access in progress. We have a good situation nowadays. We have difficulties in the local MDTs and the guidelines because we have a local guidelines for each center and hospital, and this varies between the major cities in Iraq. And the ongoing update, the investigation and the treatment update, experience and the training, all we need to improve our experience in new agent and the new treatment modality. Thank you very much, and I hope I'm not so fast. I'm not It was informative presentation. Thank you very much.
Good afternoon, ladies and gentlemen, honorable chairpersons, and all of my esteemed colleagues. This is Dr. Hein Tayzar Zoe, consultant medical oncologist from Bogon Oncology Center, Yangon, Myanmar. Today, I'm delighted to present to you how I treat cancer when I don't have the drugs in gynecologic cancer. Okay, this is the gynecological cancer management. Cancer is emerged as the leading cause of morbidity and mortality worldwide. And its burden has been particularly overwhelming in developing countries while access to cutting-edge treatments and healthcare resources is often limited. In these settings, the clinicians are tasked with delivering the best possible care to their patients and limited resources, making every decision count. However, its adaptation in developing countries has been slow, largely due to the economic constraints, infrastructural limitations, and the lack of specialized knowledge and training. What should we do when we don't have the drugs? I will discuss about the 10 facts: early detection, strategy, diagnosis and staging workup, surgical approaches, palliative and supportive care, radiation therapy, community engagements, adaptation of treatment protocols, collaboration and networking, and patient education, research, innovation. So first of all, early detection strategy. As you all know about that, early detection of cancer is a very important thing. So signs and symptoms of the cancer should be aware, and periodic examination should be done in suspected signs and symptoms. Encourage the cervical cancer screening, pap smears or HPV testing like that, and ultrasounds and transvaginal sounds. Sometimes the tumor markers should be checked if clinically indicated. Number two is the diagnosis and staging workup. And cancer diagnosis should be made at the clinically, imaging, biopsies, and the tumor, sometimes the tumor markers. And then staging workup is a very crucial one, and just X-ray, ultrasound, CT, MRI, or the PET CT as the clinically indicated. Another one is the surgical approach. There are surgical intervention, including the minimally invasive procedure when applicable, biopsies, surgical staging, and some of the definitive surgical management, debulking or cytoreductive surgery or palliative surgery, depending on the case of the patients. And then another one is the palliative care. As you all know about the palliative care is also the important one in our developing country cancer management. And early integration of palliative care, prevention and screening, and pain symptoms assessment, symptom management, and sometimes there may be ostomy and fistula care, psychosocial support, hospital care, analyte care, and bereavement support. And the main focus is to improve the quality of life of the patients and family. Another one is the radiation therapy. As you all know about the role of radiation therapy in gynecological management is a very important one. As a treatment modality that should be more accessible in resource-limited setting. The role of RT in gynecological cancer is sometimes the definited or the CCRT, and then the palliative therapy. And in all our developing country, the waiting times of the RT is too long. So we have to count into the waiting times of the RT in government center, and then another have to be the private sector. And the private sector, the cost of the RT is a financial factor, is also consideration for the radiation therapy. So another one is the community engagement. Community engagement is also important. As you all know, some gynecological cancer present with a late stage due to the culturally sensitive issue. Emphasize community involvement in prevention, screening, management, and leveraging local resources and traditional practice. For culturally sensitive, tailor educational materials and program to be culturally sensitive and relevant to the community belief and practice. Address cultural taboos and misconceptions that may hide discussion about the gynecology head. So, as you all know about the non-WD social media platform is a part of the community engagements in cancer prevention, detection, and the management. And we have to train community health workers regarding prevention, screenings, and management. Another one is the adoption of the treatment protocol. In our country, according to the Global Can 2020 data, cervix is the most common malignant malignancy in the female. So in other cells, the ovarian, uterine, and gestational reproductive disease. This is the guideline of the cervical cancer stage and the treatments, including surgery and ABRD of the best supportive care. And all know about as you all know about the decision points. Decision points is the surgical oncologist and also decides if this is the operable or the resettable. This depends on the tumor factors, patient factors, financial factors in our resource limited country, and the facility factors of the how the treatments can be delivered. If the resource limited setting, if the EVRD or unavailable, neoadjuvant chemo, followed by radical hysterectomy. If the brachytherapy unavailable, plus RD plus minor concurrent chemotherapy plus radical hysterectomy. If brachytherapy and surgery unavailable, plus RD plus or minus chemotherapy. In the resource limited setting, our summary of the cervical cancer management is surgery, adjuvant chemo, during RD waiting, if that's surgically operable or resettable, and then RD or CCRD plus or minus brachytherapy. Sometimes there's absolute indications of the RD. As in the government center, we have to wait the RD for 6 months. So initial chemo during the was given, and after that, RD or CCRD plus or minus brachy was given. And the medicine, as you all know about that, the best supportive care palliative chemo is more than one. This is the most common systemic chemotherapy in cervical cancer patients. And uterine neoplasm, as you all know about, the present with the bleeding PV, post-coital bleeding, the post-menopausal bleeding, or like that. And sometimes the patient is consulted with a GP or OG oncologist, or like that. Diagnosis and staging work at one history, first examination, imaging, and biopsy as the clinically indicated. So, endometrial epithelial carcinoma management is simple. And disease limited to the uterus or suitable primary surgery, total hysterectomy, and PSO was done. If the disease limited to the uterus, not suitable primary surgery, and sometimes intention chemotherapy and RT. Sometimes consider hormonotherapy in the patient and best supportive care. The summary of the endometrial management is surgery followed by adjuvant chemo during RD waiting, EBRD or brachy or like that. Sometimes as after surgery, brachytherapy were given, sometimes observation. And metastasis, best supportive care, validate chemo, hormonotherapy in the systemic setting. This is the systemic therapy of the endometrial cancer. This is the ovarian cancer workup, abdominal pelvis exam, ultrasounds of the abdomen, CT, MRI as clinically indicated, chest CT, chest X-ray are clinically indicated, and some of the blood count and tumor markers for the monitoring of the disease product. Decision point is also an important one, that if the patient is surgically and operable and resettable, hysterectomy or PSO is followed. And then the post-surgical indicate a low likelihood of the optimal cytotoxic reduction, then neoadjuvant chemotherapy and recess for the surgery. This is the systemic therapy of the various ovarian malignancy. Gestational thyroid disease is also common in our country, that the burden of the HMO or GTN or like that, there is a major risk score, and we give the according to the guideline, the treatment of GDDs like the DNC, hysterectomy, septicectomy, and in low risk that we prescribe this agent systemic therapy, and high risk narco or like that. Response assessment and follow-up should be done with the HCG assay. So we are discussing about the metronomic chemotherapy and gynecological malignancy. The concept of the higher the better. The concept of the higher the better has been challenged by the more frequent the better. And more evidence from the randomized phase 3 clinical trial has shown that the dose chemotherapy in which one or more chemotherapeutics are administered at more frequent intervals has a clear benefit, like the C breast or like that. But the second concept that the cancer is a chronic disease, it should be treated like other chronic disease was proposed. Control of the cancer was expected to be just like the control of diabetes, though it might be more critical and complicated. The strategy of the treatment of cure is being replaced by the treatments for the stability to maximize the survival of the patient with the advanced cancer. Conventionally, cancer patients are usually treated at or near the maximum tolerated dose with the implicit intent of eradicating and curing the tumor after balancing between efficacy and tumor killing and toxicity to the host. The practice of the metronomic therapy has been increasing interest in putting more effort into administration cytotoxic drugs on more continuous basis with a much shorter break period or none at all, or generally lower dose of the various cytotoxic drugs or combination with other neuros guided therapy like the anti-angiogenic agents. But there are still many unresolved problems and the controversy exists. But the main focus is to improve the quality of life of the cancer patients and family. And another fact I would like to discuss about the collaborations and the networking. Collaborations and networking are essential components of the gynecologic cancer management in resource-limited setting. By fostering partnerships and creating networks, healthcare professionals, organization, community can pool resources, share knowledge, and collectively address the challenges with the gynecological cancer. Here's the multidisciplinary collaboration, public-private partnership, international collaboration, capacity builds and trading, resource sharings, regular conference and workshop like that. Are the key aspect of the collaboration, networking, and resource-limited gynecology cancer management. And patient education. Patient education is the critical components of the effective and gynecological cancer management in the resource-limited setting, providing patient with information about prevention, early detection, available treatment option, empower them to make informed decisions about their health. So we have to focus on the preventive measures like the HPV vaccination, encourage regular checkup like the pap smear or like that. And the last one is the research and innovation. Research and develop course of the treatment modality should be done and investigate the facility and implementation, organize screening programs and validation programs for the HPV in resource-limited setting. Research and advocate for the health system strengthening in resource-limited setting. Engage in resource translation to ensure the evidence-based practice are incorporated into policy. Advocates for the policy changes that support sustainable and effective gynecology cancer management. So in our country, Myanmar National Comprehensive Cancer Control Plan has also planned for the 7th strategy, including the primary prevention, early detection of cancer, improved effective diagnosis and treatment of cancer, improvement of the quality of life of the cancer patients, documentation of the cancer patient, surveillance and research, radiation safety. So this is our cancer center in Myanmar, and building the medical oncology center and the radiation center. And radiation centers, there's 12 centers, 4 are private and 8 as the government centers. So in conclusions, early detections and the screenings that save lives, communicate and engagement is the key. Also, innovation in health technology, telemedicine, mobile health solution to overcome geographical barriers and increase access to the gynecological cancer prevention, diagnosis, and treatment. Multidisciplinary collaboration matters, and then should be prioritized with the palliative care and base sustainable community support. Advocate for the policy changes that prioritize women health and allocate resources for gynecological cancer management. Policy support is essential for the sustainable improvement in healthcare infrastructure and service delivery. Okay, this is my sincere hope that the information and insights are presented in this presentation will empower clinicians to deliver state-of-the-art cancer care, improve patient outcome, contribute to the growing body of the knowledge in the resource-limited gynecological malignancy management. Together, we can overcome the challenge and disparity that exist in cancer treatments and make strive towards for future generation. Thank you so much.